So I'm going to take us back to the white paper and signpost you to some of the items that we feel are really the great take-home messages for you, and for you to take away and basically kind of tell 5 of your colleagues and tell them to tell 5 of their colleagues, so that actually the shared language of human factors and the goals we've got for collaborating between healthcare institutes, healthcare workers with HFE professionals really does snowball through the system. So initially, we've got our strategies to give human factors in health and social care the best possible chance of success. And Sue talked about a case study and alluded to the idea that actually through early implementation of human factors, we avoid the need for retrofitting and can avoid errors in the long run. And here we've got a simple graph just to show the opportunities that good design and a systems approach actually then have in that long-term view. If you get it right for the people at the start, then you get it right for the system overall and in the long-term view. We know that through taking full account of human factors activities from start to finish and in ongoing surveillance, we get the best possible impact. And this has already been demonstrated in the medical device industry, where products are being developed with input from all users right from the very start. And companies are seeing that benefit as they take their products to market. This process should be replicated in healthcare systems. In our groups, in our workshop earlier, we talked about understanding the needs of the users very early on, and at that point, once you get it right, it feeds through a positive process where those iterative loops are just building on positive practice, understanding what is good, what goes well, and where that is the case, you can then build on it and communicate it more widely. Where things are going wrong and improvements can be made, we can then start to understand why people are working in that way, why the system works in that way, and then how we can improve it. I think this is a really important one. We want to encourage the formalisation of the human factors process through planning, documentation and reporting. That would occur in any other safety science. It would occur in all of the clinical practices and disciplines that many of you are operating in. You wouldn't undertake a procedure without documenting, understanding what happened, and then kind of reporting it. So we're advocating that you take the same approach with human factors, that it's planned for, designed in, right from the very start. And then through that documentation, again, there's this positive loop where we're improving the system through understanding what has happened and why. We can do that through ensuring that it's design-led as well. I've mentioned the early implementation, but getting the design right, maximising the potential for improved safety and efficiency, and minimising the potential for risk and error within the system can all be improved through this documentation process where we understand what has happened and why. We obviously want it to be proactive and early, but sometimes it won't always be. And when human factors practice is reactive in some ways, we need to be asking why an action made sense at the time, or why somebody does something in a certain way. And here I've got 2 pictures. The one on the right, sorry, the one on the left doesn't make sense in isolation, but when you understand that these workers are actually welders on a construction site, and they're not provided with the adequate PPE for their job, and that they've had to fashion their own makeshift one, you suddenly start to understand that by taking random bits of rubber or cardboard to protect their faces because the system and their way of working doesn't provide for it, that makes sense. But in isolation, we don't understand that at the start. So we need to observe people, we need to talk to them, and we need to talk to them while we're observing them so that we actually understand what is being done in the moment, in practice, rather than work as imagined, so when people are telling you what they think has happened. And that's a really important part of documenting how we can improve systems. Another strategy, or brilliant basic, this is our other kind of coined phrase. We think actually it's a brilliant basic for using HF expertise to understand what can be done better and to understand where, how and why the system is working safely and efficiently. So it's taking this positive approach as well as understanding the negatives within the system to make it more resilient and to really capitalise on the good practices that do happen. We want to understand workarounds. I'm sure you've all experienced and seen the random post-its or notes that are left for somebody coming on the next shift and, you know, with their colleague telling them that they don't forget to do it this way because such and such is broken or so-and-so is not here. And actually those kind of flags are signposts to work that is being done rather than this work as imagined. We've got lots of procedures in hospitals and health and care provision, but actually work does not happen on the ground as we expect it to, and we need to understand what is actually going on. We also need to create inclusive solutions so that products and services are accessible and usable to the intended users. Sue said about all the users that are involved, and that will be staff, patients, the public, and also management, logistics, administration, the cleaners. We have a responsibility to understand the needs of all of those people and make sure that they are designed for, and at that point we can get solutions that work in the context of the wider system. This little image down at the bottom is a piece of work that was done at Nottingham not so long ago, and it was in response to some clinicians understanding that there was a problem within the process for providing resuscitation to premature babies being born, and there was a requirement or a statement of need for a piece of technology that could potentially help in recording accurate heart rate rather than stopping resuscitation for manual heart rate. And the engineers and the clinicians came up with a really novel piece of kit, but actually hadn't involved the maternity team, so the midwives, some of the nursing staff, and actually, crucially, the patients and their spouses, so if it's a mother giving birth. And so we were brought in and we had the opportunity to work with multidisciplinary teams and help to take that development of the design and the interface further so that it went beyond the needs of just the consultants and the very experienced sort of like high-level staff to incorporate the needs of nursing staff, more junior nurses who might get involved in those resuscitation. Obviously it's a point of care where people just have to get on board to help the situation and try and provide the best outcome for the baby and the mother. And so actually this product has now gone out to market, and the nice thing is we were able to support their understanding as well of how technology can fit into a clinical pathway. It doesn't have to be disruptive, sometimes it is, but actually we know, and from the work that has been undertaken, that this contributes to safer working practices and better outcomes for the patient. It helps the staff do their job accurately and successfully. So in addition to the strategies, the white paper signposts to what good HF looks like. This section is kind of, many of you may kind of know, it might be a case of preaching to the converted, but when it's done well, it can really help recognise and provide for human need, and particularly to optimise human capabilities and mitigate the potential for physical, cognitive, psychological and social limitations to impact how a person is working in that moment. It can design out the potential for people to make mistakes and helping them succeed in what they do. And I think that's a really crucial point, in that if we can help build and develop systems and interventions that support that user, it frees up time for quality care. And that's why we're all here. When HF is done well, it can also, ultimately, it can help minimise the need for training or frequent recourse to instructions. And Sue mentioned this actually, but I think it's really important to remember that training is the least resistant barrier to errors occurring. It really is the last point of call. Once you've gone through the process of designing in solutions that prevent the error occurring first and foremost, providing a barrier in some ways that might not be as strong or as resilient as the prevention strategy. You then need to mitigate the risks of potential harm if the error does occur, but training really should be the last port of call, and I think this is something we can all really get behind, knowing that those interventions in that order provide the best opportunity for care improvement, and that's what good HF looks like. We want to standardise terminology and encourage consistency in interactions. That will be within and between people, places and equipment. And in our workshop there was some talk about, on one of the tables, about duplication of actions and the frustrations that causes for staff and for patients and everybody involved, because it's extra workload, but then also what's the point? And if there is a point in terms of ensuring we've got the right information for patients and that safe procedure is occurring, then great. But if it's duplication that doesn't serve a purpose, then we can take it out. And this is what good HF looks like. So I'd just like to kind of set this up as well against the kind of, and its importance against the changing landscape of health and social care provision. We know that technology is ever more pervasive, and the applications of novel technologies like artificial intelligence, remote monitoring, all sorts, digital health records. It all serves a purpose, but are we getting it right? There are great opportunities with technology implementation, and by using human factors to ensure that the technology is used and developed in the right way, we can really truly maximise on its impact on health and social care provision. All of this technology as well facilitates distributed working practices, which weren't possible years ago, or a couple of years ago. And again, that introduces complexities and challenges, but if we design it properly and understand the impact on clinical pathways, on care systems, then actually we can get that right to the satisfaction, the experience, and the improvement of the service for everyone. Some of you, a lot of you will be on the receiving end of the changing role of the patient, and their involvement in decision making, and actually the value that is had from good patient experience, where potentially if there are delays, it could cause frustration, but if they understand the delay, why the delay has happened, and the experience in other ways is made more acceptable, then actually no value is lost through that. We've also got the kind of national and globalised personalised care and public health agendas. So human factors can help to provide insight on those, whereby either through technology or ways of working, we can help forward those agendas in the most efficient ways possible. And finally, just obviously this white paper is about health and social care, and increasingly as those two start to come together, that complexity of that integration, it provides significant challenges, but there's no reason why it shouldn't work if we design it well. And just quickly, I've talked a bit about value, and the value proposition for healthcare is changing. We know that so much is driven by that economic value proposition, the upfront and long-term costs, and that decision making does revolve around those. But actually, there are other ways of thinking about that. We know that if we can improve service user experience, if we can improve staff well-being, then that actually then feeds into the allocative value, the technical values, which then subsequently go full loop to improve the economic value, where we've got improved experience, improved productivity and performance and safety that all lead to better clinical outcomes. It's not easy, but actually if we start with the people, then there is that flow of value that goes through the system. And just quickly, to round up before I pass on to Paul, I'm going to signpost you to the case studies. There are some included in the white paper itself, and actually the Chartered Institute has got some great resources that are available if you want to do some further reading. They're not big, long documents. You can pick them up 5 minutes on the train or something. But the Human Connection, we've got version 1, which was published last year, and version 2 this year, provides some really excellent examples of human factors in practice, some of which are healthcare specific and some of which are coming from other domains. But actually, if you want to kind of think about what human factors can offer, these case studies really do offer something quite tangible for you to then consider how it might be applicable to your area, but also to start those conversations with management, to start the conversations with procurement and commissioners, and to spread the word in that way as well.